I'm Dr. Milica Vukićević, a Harvey scholar at the Brigham and Women's Hospital campus of MGB Heart and Vascular Institute, bringing you Heart Failure Minutes. Today I'm joined by Professor Mandeep Mehra to discuss the CAVIAR trial just presented at the American Heart Association sessions in New Orleans. The CAVIAR trial, a Stanford-led study, explored whether the PCSK9 inhibitor alirocumab can slow cardiac allograft vasculopathy after heart transplantation. While alirocumab significantly reduced LDL-C, it didn't reduce plaque progression, raising key questions about whether CAV is primarily driven by lipids or by immune and inflammatory mechanisms. So, Professor Mehra, where have we come in understanding the pathophysiology of CAV in the past several decades?
Well, we've learned that statins not only reduce lipids but also exert several pleiotropic effects. These pleiotropic effects include reduction in inflammation and an improvement in endothelial function. In fact, in heart transplantation, this property is very, very important because we know that the earlier we begin statin therapy after heart transplantation, the greater is the benefit in reducing mortality. And more importantly, this mortality is reduced by a reduction in hemodynamically significant rejection events. This property appears to be independent of its lipid-lowering property. The CAVIAR trial is, of course, extremely important because this trial tested whether incremental and more intensive lipid modification early on after heart transplantation, in absence of these additional pleiotropic effects, would also reduce plaque regression and improve the future genesis of cardiac allograft vasculopathy. Now, in this particular situation, we have known for a while that targeting LDL is not necessarily clear in heart transplantation. Whereas in general, native atherosclerosis, reduction in LDL down to very, very low levels has appeared to be very safe and highly effective. So the CAVIAR trial, really in a randomized control format, testing a PCSK9 inhibitor to placebo, done very rigorously by our colleagues at Stanford, tested this particular hypothesis.
The CAVIAR trial included well-treated patients already on rosuvastatin. So given baseline LDL-C levels around 70s, was the trial essentially testing beyond threshold lipid lowering? And can you tell us what would an ideal future study look like?
First, I want to describe that we have learned with the natural history of cardiac allograft vasculopathy that it is actually a bimodal disease. What I mean by bimodal disease is that early on in the first 2 years, the disease appears to be propagated by immune or inflammatory mechanisms. After about the first 2 years, the traditional risk factors of diabetes and hyperlipidemia and other dysmetabolic factors appear to become dominant. So in intracoronary angioscopy studies that our group has done decades ago, we showed that very early on the kind of plaque that is established is a white fibrotic plaque, whereas after 2 years, the kind of plaque that we see is a large, bulky, lipid-laden plaque. Thus, it stands to reason that what was already seen in CAVIAR might be quite intuitive. That is, if you already have a statin on board, in this case rosuvastatin, and have already lowered LDL down to about 70, in the first year after heart transplantation, incremental benefit is just simply not seen. It is somewhat surprising that there was no improvement in plaque progression at all with the additional intensification of lipid-lowering therapy with PCSK9 inhibitors. What was surprising is that LDL levels in the PCSK9 inhibitor group were halved down to about 30 milligrams per deciliter, whereas in the control group or placebo group, they remained at around 70 milligrams per deciliter. But yet, in the first year, I would say that knowing how CAV progresses, this may have been an intuitive finding, simply because there just simply was not long enough follow-up.
So with two neutral PCSK9 trials in heart transplant recipients, alirocumab and alirocumab, should these agents be reserved only for refractory dyslipidemia, or there is still a rationale for broader use in CAV prevention?
So first of all, based on the current evidence, there just isn't strong enough evidence to recommend a PCSK9 inhibitor immediately after heart transplantation on top of statin therapy. However, I just want to be cautious that this was a small proof of concept trial. It was a 1-year study. It did not enroll patients and follow them up for a longer duration of time. And given the bimodal aspect of the pathophysiology of cardiac allograft vasculopathy, it may actually be that intensification of lipids might be a late benefit effect. And so I would say that a future study should actually look at greater intensification of lipids, and perhaps in concert with better blood pressure control, the use of anti-diabetic agents, all in concert as a strategy, perhaps after the first 2 years, would be much more yielding in determining the long-term natural history of allograft vasculopathy. Yet this is a very critical study that has at least given us sufficient evidence that there is no compelling reason to initiate intensive lipid-lowering therapy in the first year after heart transplantation.
Thank you very much, Professor Mehra, for this excellent perspective. This is Dr. Milica Vukićević signing off for now. Until next time.